My name is Bee Bakshi. I am a GP by background and also one of the co-founders of See the Signs. So this is going to be a demo walking you through the See the Signs cancer platform, which is available in all practices across DHR as well as within Newham, Waltham Forest, and is being used in Northwest London, Southwest London, Oxfordshire, alongside BHR. I'm going to show you the tool, but also walk you through a demo, how the tool can be used, how the safety netting dashboard can be used as well to show you how safety netting is done, and also touch upon the PCN DES and the quality improvement QoF module and how See the Signs can support you and your practice to achieve the cancer requirements quite seamlessly in order to get your practice income at the end of the year. Just to say, if any of you are logging in via a smartphone, just to turn it landscape for the demo, which will just be easier for you to see. I'm going to share my screen now and do a demo within the EMIS clinical system, and then we'll leave some time for questions. So please do, if you think of any questions along the presentation, please put them in the chat and we'll pick them up at the end of the presentation. So So this is the See the Signs toolbar. The first time to launch it, you'll need to go to your Windows Start menu on the left-hand side, and you'll see the Signs in the Windows Start menu. So if you've never accessed See the Signs previously on a terminal, you will need to launch it the first time. The first time you use it, you might be prompted to enter a practice username and password. Your practice manager has been sent the practice username and password. But if you can't find it, just email us. I'll submit our email address within the chat group at the end of the session, and we can send that through to you. Once you've been able to log in or access for your practice, you'll just be encouraged to sign up to the tool. After the first time you've signed up to the tool, we will sync your EMIS login with your See the Signs login, and it will automatically launch and log you in thereafter. So this is the See the Signs toolbar. It will launch automatically each time you log in to EMIS. As you can see here, I've got a patient up already, which is Lisa Ellis. Just to say that this is a test environment for EMIS, so apologies in advance if there are any issues. So the See the Signs toolbar, you can move it around if you'd like to shift it from your toolbar. You can also shrink it. I know sometimes your toolbars that you might have a few toolbars and it might be quite busy, so you can shrink it and move it around as well, or you can minimize it to the bottom of the tray if you wish to do so. Again, it's there to access quite easily, but also to serve as a prompt that sometimes during the consultation, just to think cancer with some of the patients, to consider cancer referrals. The first button on the toolbar is for everything regards to cancer risk assessments, accessing the cancer 2-week wait referral forms, and also cancer resources. This will mainly be used by the clinical team at your practice. The second button along is your practice safety netting and data dashboard. So this is for all patients who are on a suspected cancer pathway where they are safety netted onto. It will also have a list for your cancer confirmed patients and also contain your practice data and your PCN cancer performance data. And this most likely will be used by both clinical and administrative teams at your practice. The last button is just your account information. And if you'd like to contact us through help, FAQs, or if you'd like to request training as well. And some of the training videos are hosted directly there if you'd like to access them. So I'm just going to walk through a risk assessment. So I've got a patient already up, and I'm just going to click the first button. So you can see that on launching See the Signs, on the left-hand side, you've got the Barking and Dagenham CCG. So you know you're in the correct CCG for your practice. You'll also see which patient you're on, and that's just to be helpful to you if you have, just to make sure you're currently risk assessing or conducting a referral for the correct patient. On the left-hand side, there is a notice board, and this is just to deliver updates, news, and changes to any cancer referral pathways, any changes, as well as any new services that are available within your area. Just to make a note that within the tool, everything is essentially compliant to the NICE cancer guidelines and then fully localized to reflect the cancer pathways available in Barking and Dagenham CCG. All referral forms are the London referral forms. We host them centrally and enable you to access them quite easily, as you can see in the drop down below. When you do access a referral form, you'll see on the left-hand side that we actually embed the patient information leaflet into the referral form. So making it very easy for you to essentially text a patient or open the leaflet and print it if the patient is in front of you. For real patients, the mobile number will be pre-populated. For the 2-week wait cancer leaflets, they are available in multiple languages. So you can just select the drop down, select the language you'd like to send it in, and then click send. For the referral form, you can see that the patient demographics and information pre-populate. It's not protected like in a Word document, so very easy to mark for any breast lesions or anything like that. And it will pull the clinical information, any past history of cancer, investigation results, and medical history. We do pull relevant tests and investigations just going back 6 months. And for medical problems, any significant past or active past, but there is a level of screening done so you don't end up sending 30 or 40 pages of past medical history or background history over to secondary care in order to make sure that only relevant information is sent. Once you have a form up, any form, you will also see that sometimes when you try to say generate the form, if a box hasn't been ticked, we will signpost you to that. And that's just to make it easier for you, because sometimes these forms have many boxes and it can be difficult to know which boxes you need to tick in order for the referral to be successful. And many of you will have previously experienced where a referral form has been rejected or declined because a box hasn't been ticked or a certain question hasn't been asked. So this is just a really easy way to prompt you to say, this is an outstanding box that you've not seen, so you can tick them and then essentially proceed to generate the form quite easily. I'm just going to go back here just to let you know with respect to the referral forms that there is a Pan London update you might have received the communication for in your CCG comms this week, where all the referral forms have been updated, but there's 3 significant changes to the hematology referral form, upper GI referral form, and I believe 1 other referral pathway. Just to say that these changes will be going live tomorrow morning within the See the Signs system. So again, when you log in, you'll see the forms will have all been updated. You'll also see that on the notice board, there will be a summary link to inform you of what those clinically relevant changes are for you to read them and just access them in a really digestible way. So that will be there for you to review from tomorrow. From a risk assessment perspective, there are 2 other options. So you can risk assess via search. So this is really when you have vague or non-specific presentations. Sometimes you might have a patient who just comes in with, say, nausea, and you might not know what to do with them, if they qualify for a 2-week wait or not, you know, or is it a test, is it an endoscopy, or kind of more rarer types of abnormal results. So for instance, seroleukocytosis, often we might not know what to do, but the opportunity here is that it will funnel you down the correct tumor pathway. So a raised white blood cell count actually is a sign of a urological malignancy, and actually this patient could be risk assessed then down the urological tumor pathway. Just to say that every single sign, symptom and risk factor that features in the NICE cancer guidelines and the Pan London guidelines is available here. You can free text it, or you can click on any of the letters and then be taken to the shortlist. Where there are multiple tumor pathways that features that sign, symptom or risk factor, you will be taken to all of them. So thrombocytosis actually features in several tumor pathways, and you then have the option to search across all tumor pathways in one go, or you can deselect some and just search across the ones that you may suspect the most. Lastly, the next option to risk assess is system. So this is when you may have a suspicion of where the symptom is coming from, but you are not sure if this is a 2-week wait or cancer pathway, and if it needs to be a referral or if it's, say, a test or investigation to send this patient for. Similarly with the search section, you can select multiple pathways at the same time that you'd like to search across. So if you have a woman with abdominal pain, you might want to search across GI and gynae at the same time, just to cover for both malignancies. When you do select a tumor pathway, you'll see on the right-hand side, you get shown the risk assessment. It's broken down into risk factors, symptoms, signs, and investigation results. So this is mimicking essentially the NICE cancer guidelines. Age and gender will pre-populate, and then you just select any of the positive symptoms that the patient has attended with. So I'm just going to click on abdominal pain and change in bowel habit. What you'll also find, and this is the way that people have been using this aspect of the tool during COVID, is that a lot of patients will trigger purely based on risk factors and symptoms alone. And that's partly down to the NICE cancer guidelines and how the threshold for referral has dropped in order for us to be able to refer more patients in order for us to pick up more cancers earlier. So this element can really help when you're thinking about triaging patients to say, especially over the phone or virtually, to say, do you need to bring them in? Or is it the case that they need to be fast-tracked to a cancer referral or a certain test or investigation that you can do either alongside that while they wait to see you, or outside of that? When you click enter at the bottom of that form, you'll then be taken to the results page. So you can see here we've got the results. This is a 57-year-old woman with abdominal pain and change in bowel habit. So you can see here that she's triggered GI pathway, and we were in the GI section, but she's also triggered a gynae pathway and also the rapid diagnostic pathway, even though we weren't in those sections. This is just a safety net feature that's built into the tool, which means that regardless of where you are, all eligible pathways that the patient can be referred along are shown to you. So even if you are searching in the gynae section, if the patient is eligible for a GI pathway because of the symptoms that you select, we will show that to you in this results page. And this is why sometimes you might see pathways that you weren't suspecting, or that might seem a bit random. So for instance, like the rapid diagnostic clinic here, but it's just to demonstrate to you that this patient is eligible for this pathway and for you to consider this when you're making your decision about which pathway to go down. You can see that it's a combination of tests and investigations and referral pathways that are recommended. And anything that is recommended essentially is above a 3% threshold of risk of cancer. So based on this, technically, based on the current guidelines, you should definitely consider, especially when it comes to tests and investigations, looking at investigating these patients. Where there are multiple test investigations, you might consider doing them all together, or you might think about doing it in a systematic way where you might do some of these investigations and then come back to it if they're excluded, to actually then think about where else do I need to be thinking about cancer for this patient because I've just ruled out cancer in that tumor type for that patient. When you scroll down, you'll see that the corresponding patient information leaflets based on the pathways that are triggered are also presented. So again, just trying to make it really easy for you to access patient information leaflets and to send them to the patient. So you can see here, we've got the rapid diagnostic clinic leaflet for BARTs to complement the RDC. You've got the FIT leaflet to complement the FIT, and same with the urgent 2-week wait leaflets as well. So again, you just can press text to text them, or you can download them and print them to the patient. So at this stage, if you think that actually none of these are appropriate for my patient, or you know, either down to your patient's performance status, or maybe your patient isn't keen to go down these pathways, you can choose to do nothing and just close see the signs, and then nothing will be saved into the notes. And that's really just important to say that it's down to your decision making. It's not to force your hand or hold you to account to do anything. Only the ones that you select will be saved into the notes and then safety netted. So again, it's really up to you to say what tests and investigations or pathways you would like to choose to action. And there there be it making with it. I'm just going to show you also, I'm going to access the RDC. There's an additional column here which says defer. And this is really something that was launched in response to COVID, where many patients may be triggering cancer pathways, but because they're shielding or they're COVID positive, or, you know, they're not comfortable going to hospital at this time, you may need to defer their referral and then consider sending that 2-week wait referral maybe in a couple of weeks' time, when it might be appropriate to do so for those patients. So this option here really is to say, how can you safety net these patients in a way that you can keep track of them for later referral. So if you do select to defer a patient, you will see that they are also added to the safety netting dashboard, but nothing is actioned, just the case that that test or investigation has been deferred, and you will then have the opportunity to action it at a later date when it's safe to do so for that patient. So I've just selected the RDC pathway, and I'm just going to click now proceed to referral form. So when you click next, you get taken to the correct corresponding referral form. In case you haven't sent the leaflet, again, you have another opportunity to text the leaflet to the patient on the left-hand side here. And you'll see that the referral form will be pre-populated with the risk assessment we just did, and it will pull the corresponding information, and I'll just click that. And then again, you can see that I've been prompted, I've not done performance status, nor this box here, and then I'll click generate form. So at this point, you'll just get a summary of everything you've done, and you can free text around this box if you'd like to add any additional information or any examinations you did or anything outside of what See the Signs has captured. And then I just click save. And you get a success message just there to say that it's been saved. So now if I go into Lisa Ellis's notes, I can show you what that looks like. Just to say that I spent a lot of time obviously talking through the different options. In real life, when you get used to the system and you know that you're going to go straight, say, into the gynae section or the chest section, it's a lot quicker, where you just click a couple of buttons for signs or symptoms or risk factors you're worried about, and then click next, and then it's done. Same way, if you want to access referral forms very quickly, you can see that within a couple of clicks, you can get to the referral form and then complete that. So in a real life environment, it is a lot quicker, obviously slower because I'm talking you through. So really do consider thinking about doing this during the consultation, when, you know, you might be thinking, do I tell the patient it's an urgent referral? Do I tell the patient, you know, I'm going to do a routine referral, or do I refer them for, say, like an ultrasound or a fit test? So all of that uncertainty that you might be thinking during that consultation, when you're having that dialogue with a patient, you can really consider using See the Signs to help facilitate that decision making, to say, actually, you know, she or he qualifies for a 2-week wait. Okay, let me just go down that pathway because, you know, it's made my decision slightly easier. Or similarly, you might see that actually this patient doesn't qualify for a cancer referral pathway, which helps validate the kind of conversation you have with the patient to say, actually, you know, you're not at risk. There is nothing to suggest you're at risk. So I'm going to do a routine referral. So you can also consider using it for both ways with patients to help reassure them, even when, you know, you're not suspecting cancer, but you just want to double check to reassure the patient as well. So just take you back here, you can see this is the assessment I've just done. So you can see that the change in bowel habit and the abdominal pain are coded back into the system. You have a summary of everything that's done. And then here you've got the fast track cancer referral form that's coded back in, the suspected malignancy that's coded back in, and the cancer safety netting code, which is a new code that's automatically coded back in for all patients. And here we have the referral form as well, that's saved in, and then can either be attached to ERS by yourself if you do it, or by your administrators or office team if you ask them to do it. Just to say at this point is that if your patient even triggers a fit test, that fit test will be saved, coded, and that safety netting code will be added automatically. So anything you action from See the Signs through any route, whether it's the referral route or search route, will be coded, saved back to the notes with the cancer safety netting code. So if it is the case that you wanted to run a search to see which patients have that cancer safety netting code, you can still do that. However, what I'll show you shortly is that patients are automatically safety netted onto your practice specific dashboard. So this is essentially a process to reduce or prevent any manual reliance on running recalls or running searches as a practice. So to remove that admin burden completely. And also, so as a practice, every single person within that practice can access and see which patients are on a suspected cancer pathway, not only a select few that run a recall either at one point during the day or every few days or things like that, where the knowledge is only kind of accessed by a few people. So here you can see on the second button along that I've opened, the practice dashboard, Lisa Ellis is automatically added to that dashboard. If I drop down, you'll see that we've got the date and the doctor who's referred Lisa, the presentation, the working diagnosis, what the plan is. So all of this is captured automatically for that patient. If I was an administrator, and the way that we encourage administrators to kind of work and interact with See the Signs is to have the practice dashboard open in the background. So as soon as the GP has done the referral in the consulting room down the corridor, actually you can see automatically this has come in here. I can see from the waiting time, it says 0 days. So I know it's just been done. If I drop down, I can see it's a 2-week wait. I can now go into the notes and make sure that referral is attached and sent via ERS. So again, this is to alert all the administrators as well, looking at the dashboard to say that what referrals have been done today that need actioning today as a fail-safe in case they've not seen your task or the task hasn't gone through or the urgency of the task hasn't been flagged. That information will be captured here. There are quick filters along the top. So if you as a doctor just want to see your patients, you can filter. And if you are just chasing test and investigation results, if you've got a busy dashboard, you can filter it by what you'd like to chase. So for instance, a common one that people will be chasing is fit tests. So, how many fit results do we have outstanding, and have these patients dropped their sample back in or not? Do we need to chase them to make sure they do? It's really important to consider your tests and investigations as well. As part of the QOF and the DES, you need to be demonstrating that you're safety netting all patients, including tests and investigations. And currently, unless you're running recalls or searches for those tests, a whole cohort of patients are being missed when things like FITs and CA125s are cancer pathways. And often what you'll find, and I'm sure some of you may have experienced SEAs where a CA125 has been missed or a FIT test result hasn't been returned or hasn't been actioned, and there's been a significant delay to diagnosis and as a result patient outcome. So again, this is a really easy trackable way to keep an eye on all your tests and investigations as well as your cancer referrals. It's also the case that you might not use See the Signs and you might give a fit test out in a consultation. And if that's the case, you can add patients then directly onto the dashboard for safety netting if you've not used See the Signs, or you can even task an administrator. Some practices have a procedure that when the patient leaves the consultation, they pick up the fit test from reception. And at that point of picking up the fit test, the administrator adds them to the dashboard to say that fit test has been collected and patients walked out of the practice. So there's many ways that you can think about how you do safety netting with tests and investigations. But generally think about having a process as a practice, because otherwise people will slip through the net. Just to say also, locums can access this. So it's a really good opportunity for part-time staff, locum staff. So you're not handing over your cancer patients. You're not tasking yourself to chase this chest x-ray in 2 weeks or chase this. It really is about pushing workload away from your personal inbox and your personal responsibility and looking at it as a practice-wide process that removes reliance on you and creates a safer system across the practice, that there is clear oversight of what's happening with that patient, how long they're waiting and what they're waiting for. Just to show you, the second tab along is the deferred board that I mentioned. So any patient who's had any test results that have been deferred will come on here, and there'll be a time here that will say how long they've been deferred. You can add a note to say, anything that's relevant. So I've just said refer when back from holiday in 2 weeks. So this makes it really easy for even the admin teams to know that they will only contact you, the doctor, in 2 weeks' time from the referral date to then do the referral. So again, a better fail-safe mechanism from that process. When a cancer is diagnosed or excluded, there's a couple of things that you can do. One is when you select the outcome, there are a few options. If this was a fit result and the fit test result came back positive, it's likely you then need to do a lower GI referral form. So here you'd consider selecting further action required, add referral, lower GI, and then I would proceed to the lower GI referral form. That would complete, save to the notes, and then a new entry would come off the back of this entry to say that a 2-week wait lower GI referral form has now been completed today for that patient, creating an audit trail from start to finish to say which route to diagnosis and what's going on with that patient, to make it nice and easy. Otherwise, if a result is normal, and majority of patients who do go down cancer pathways have a normal result, if you file it as normal, the patient will then move from the active board to the cancer excluded board. If, however, this patient ends up having a cancer diagnosed, I'm just going to say bladder, this will then be updated as well. And you'll see that this patient has been removed off the active board. And now if I move to the cancer confirmed board, you can see Lisa Ellis is here at the bottom of the board. So I'm just going to shift it by time since diagnosis to make her come up to the top. So all patients with a cancer diagnosis will be shifted to the cancer confirmed list. So this gives you oversight as a practice to all your cancer patients. You'll see the name of the patient, who's referred, who was the person who essentially picked up the patient's cancer, and then what cancer it is. As a doctor and part of your CPD, you might actually want to say, oh, I want to see how many patients I've diagnosed with cancer either this month or this year, which you can do so as well. And look at what stage you diagnose these patients and the quality of care you provided as well, you can reflect on. As a practice, you can see how many patients are currently outstanding from cancer care reviews. So you can see the summary notification here is 6. And you can see there is a traffic light system to show how close people are getting to essentially breaching their 6-month cancer care review. Once a cancer care review is completed, I'm just going to drop down. Again, you can see there is a summary of the presentation, confirmation of diagnosis and date of diagnosis. If I was to add a cancer care review for this patient and click save, that will update the dashboard, but it will also update the patient's medical record and enter the cancer care review code to it. And you can see this has now gone grey, and this has been ticked, and this has gone down to 5. We are currently in the process of updating this board for the new changes to the QOF requirements, where there is now going to be a 3-month cancer care review and a 12-month cancer care review. So you will see 2 columns and 2 sets of tick boxes required in order to complete the new QOF requirements for cancer care reviews that came from April 2021 for patients. Just to say also is that if you complete a cancer care review in the notes and you've entered the code in the notes, on a weekly basis, we run a recall on the clinical system. So we will check if there is a code that's been entered into the notes, and then we will pre-populate that onto the dashboard with the date of diagnosis and update it automatically as well on a weekly basis. So that's for cancer care reviews conducted. The cancer excluded, I briefly touched upon. This is just for audit purposes and for you to review the number of patients who've gone through the system and who haven't had a cancer diagnosed. And then lastly, we have the practice data tab. So this is really something to really support the DES and QOF requirements as a practice and the reporting requirements. And actually, if you use this tab and if you see the signs, you'll find that you'll automatically achieve majority of the DES and QOF targets, and you'll have a full audit trail and documentation required to then submit. So no additional work is required beyond just using See the Signs for that. So just to start off with is we'll show you your baseline cancer performance data. So this is the data that's cited in the DES and QOF specification for you to review as your starting point on how your practice and PCN are doing. You can see that we will show you your practices data, and we'll also show you your PCN average data the CCG average, and then England average, so you can see how you're performing for early cancer detection against all of these organizations. You can drop down and see all the practices within your PCN and review how each of you are performing, but also then as a PCN consider investing more resources or focus on the lowest performing practice in order to bring your PCN average up higher. So essentially, you can get some insights into the data from reviewing it in more detail. The latest data available is 2019-20. It's just the way how Public Health England publish it, which is sort of 18 months in lieu. And this is the reason why we then deliver the See the Signs live data, so you can get a better understanding of your real-time cancer activity data to guide month-on-month quality improvement. So you can see here that this is currently at your practice. It's defaulted to current year. You can change it to any time interval, and it will be a live aggregate of your total activity. So number of risk assessments, referrals sent, new cancers diagnosed, cancer tests and investigations requested, the percentage of patients you've safety netted, percentage of information leaflets given, and percentage of cancer care reviews completed within 6 months. So from a See the Signs perspective, this will always be 100% for patient safety netting because it happens automatically. And through using See the Signs, I hope you can see today, it happens automatically as well. So as a practice and a PCN, you'll achieve that tick box automatically. For patient information leaflets, you've seen how easy it is to do. Again, both of these are core to the DES and the QOF requirements. And the other performance targets here that we show you are really easy for you to demonstrate quality improvement for. You can also compare performance between practices. So I'm just going to select other practices within your PCN, and you can see how you're doing compared to others. And you can see your PCN total, and you can see your PCN average performance. Again, you can filter by time frame depending on what you want your time frame to be. Only for your practice can you see the breakdown of doctors and actually who is or isn't using the tool. With other practices, you can just see total numbers in order for you to get an idea of engagement, because if the numbers look a bit low, it may be because not everyone is using the tool in that practice. Just to scroll down further, we will also show you your breakdown of your cancer referrals, your top cancer referrals as a practice, and also your top cancer investigations as a practice. And if you hover over these, you'll be able to see how many cancers you've diagnosed through that referral route. So giving you an idea of what that conversion rate looks like. There is also an option to see the breakdown of all your cancer tests and investigations here and the total number. Again, just to say that is when you change the time frame, all the data below changes. So if you change it by month, you can see, for instance, how many gynae referrals and things you've done this month. And again, very easy to then implement short and achievable quality improvement to say, next month, we're going to do, say, 10% more 2-week wait referrals. And, we're going to increase the number of gynae referrals because we can see we're not doing that many gynae referrals as a practice. And then the following month, you'll be able to easily see and track that data to say, yes, we've done that, and essentially close that loop on that quality improvement. So lastly, just to show you right at the bottom is a reflections and an actions log to kind of really help you document your quality improvement and how you're reflecting on the data shown above. Again, this is a key requirement of both the PCN DES and the QOF is to think about how you're reflecting on your data. You can add a note and save it, it will timestamp it and create an audit trail then again for you to see everything. And because the dashboard is accessible to everyone in the practice, it makes it very easy for you to see kind of what decisions you made. And again, you don't need to then manually hand over any actions and things like that. It will all be here for you. Similarly, as a PCN, when you have your PCN meetings, just one person, you just need to select PCN. Just one person needs to make any notes you have with regards to your cancer activity data and any actions. And when you click save, it will save to the dashboard of all the practices within the PCN automatically. So again, even as a practice, if you're unable to attend the next PCN meeting, you'll be able to see the actions and the reflections on your dashboard automatically, regardless of that. So again, everyone will have that audit trail, both from a practice perspective and a PCN perspective. So again, just trying to make it really, really easy for you to be able to improve your cancer performance, but in an easy, automated way that doesn't increase workload in general practice. Just very lastly, I'm going to show you how some of the actions I made on the dashboard get saved back into into EMIS. So you can see that that bladder cancer that I had actioned for Lisa Ellis has been coded back in, and you've got a summary of the actions and results here. And that cancer care review that I completed for Lisa Ellis, you can see has been coded back in again with a summary of what's happened. So everything is coded and saved back into the clinical records if you action from the dashboard. Again, just to make sure that there's no additional workload and everything is simple and easy. So I'm just going to stop there. I'll just make a note to say is that we are doing a lot of practice training and PCN training. So I will put my email address into the chat box. So please contact us if you would like that. And another thing is that if you're accessing See the Signs on a remote laptop or any home devices that you would like to access See the Signs for, if you can also email us and we can send you the link to install See the Signs for you there. So I'm just going to pause there and just check if there's a note by Joe Johnson. I wonder, Joe, do you want to just come off mute and then you can give everyone the update?
Hi. Sorry, B.
Okay, Joe, I'll read it out. I'm sorry, I'm maybe. So Joe's just posted in the chat to say that the Rapid Diagnostic Clinic at Barking Hospital Trust will be going live on the 4th of May. So right now within See the Signs, the RDC referral form and pathway is to BARTS, which I know is not very convenient for all patients. When Barking does go live on the 4th of May, we will have the referral form and pathway within See the Signs. So you'll be able to refer along that pathway. Andrea or Joe, please correct me if I'm wrong, but is it the case that they'll have BARTS and Barking as an option, or will it just be Barking and BARTS will be removed as an option?
So, so we've obviously got 3 CCGs. So for Barking and Dagenham and Havering, it will be for BHRUT. But for Redbridge, because some practices will still refer through to BARTS, they'll still have the option for both BARTS and for BHRUT. So it can depend on the patient's preference. I mean, normally they would go into WIPs, but for the RDC, they would have to travel into BARTS. So they've got the choice then of BHRUT or BARTS. But Joe, I don't know whether you want to, my understanding, Joe, is that it's going to go live in Barking and Dagenham on the 4th of May, just for a few weeks prior to going live across the whole of BHRUT.
Yeah, it's going live on the 4th of May. I think we need to sort of work out whether we just do sort of 7 practices or across Barking and Dagenham.
Okay, let's not discuss that bit now, I think, but what we will do is make sure that there's a full communication out, and if we can use the notice board as well, when it does go live, so that communication will of course go to everyone. Thanks, Joe. I won't. We won't go to the ins and outs of it now because it can get a bit complex. B, I was going to ask a question though. So, because we obviously want to evaluate the process, when people log on for the first time, is it that they'll also get a survey that they will need to complete? I know it's a quick survey, but you're on mute, by the way.
Thank you, Andrea, for reminding me. Yeah, so the first time you do log in, clinical and non-clinical, everyone will get prompted to complete a survey. It's literally multiple choice. I think there's only 10 questions. And that's just really to help evaluate See the Signs. So funding has been provided for 1 year, and the evaluation is being supported by the Cancer Alliance. And hopefully, if positive, they will then be essentially a business case to continue funding thereafter. So please do, the form is compulsory, but even closer to throughout the period of this 1 year, please do send any feedback that you have. And then at the end of the year, some of you might be approached to fill in another survey, as well as interviews and things like that. So please do send some things through. I would love to also know if anyone has had a chance to use See the Signs, especially if you've had any issues or access or things like that. Please do let us know. I know we had lots of terminals that were missing early on that we had to iron out with the with Barking help desk, who were really helpful actually in getting the remaining terminals installed. If you still have outstanding terminals, again, if you let us know, we've got a really good relationship with the help desk team, and then they can just push the update to that terminal. So please, we're very, very open to help with training and support. So please do use us as a resource. I still can't see any questions. So if there is anything anyone would like to say, any comments, feedback.
Yeah, I don't know. I might put Sue. I don't know whether you want to introduce yourself to as the cancer research facilitator. You might be shy, but I don't know whether you want to just say hello. Hi, Sue.
Yeah.
You're on mute, I'm afraid, Sue.
Sue, unmute yourself, Sue. We can't hear you.
Can you hear me now?
Yes, we can.
Oh, thank you, Andrea, and thank you, Bia. Yeah. So hello, everyone. I'm Sue White. I'm the Cancer Research UK facilitator. Just started in the BHR area, and I'm filling in for my colleague Lubna Patel, who you might have met before. So I'd love to help with the rollout of See the Signs, because I heard about it many couple of years ago, I think, in the east of England, Bia, with my colleague Jay. So it's expanded even more since then. Couple of questions. One, which is Andrea's big topic, I know. Is there any sort of option within there for a teachable moment when cancer is excluded? And are you asking questions about screening as a sort of audit trail?
Yeah, so the questionnaire for survey was put together by the Cancer Alliance. So I don't believe actually they include any screening questions were included. Or if the patient isn't eligible for a cancer pathway, currently safety netting is the mainstay messaging, encouraging. But again, further messaging can be added if useful, but safety netting is the main thing. And also to consider that they can still refer on gut instinct, which is really important to note.
Yeah. So, and you talked about the DES and the QOF. So there's still the screening side of DES and QOF for practices. Is it something you might get involved with?
Yes, actually, where I showed you the PHE data, we will have an update actually. I can't tell you when, but it's in the pipeline where we will show you your screening performance data there as well. So your bowel, breast and cervical screening data. And further on from that, we're actually doing a pilot currently, or working towards a pilot to look at how we can automate screening for non-responders. So if that goes well, you will see another tab on the dashboard essentially to support non-responders, but that's currently in the pipeline.
Excellent. Thank you. Thank you, Andrea.
B, there's a message from Alex, and yeah.
It's a question about sending it via ERS. We're currently working to integrate with ERS. The main problem is that the current limitation with ERS requires it to still go through several clicks to finally get to a 2-week wait clinic and then actually book the appointment. So one of the key challenges with ERS, and I'm sure you all know, is that because it takes so long to actually get to the cancer clinic, often it's not done in the consultation and it's done by the admin team. So one of the key things we've said back to NHS Digital, who look after the ERS software, is that if we're going to kind of ask GPs to do it during the consultation, it needs to just be one click straight into the corresponding clinic rather than launching it and several clicks. So it's currently in the pipeline. We're currently working on it. We just want it to be as user friendly as possible and as speedy as possible. Next question by Sai Bald is it mandatory to send the patient leaflet? I often prefer not to overload them with information until something is confirmed. I can understand your hesitation because you don't want to worry patients, but you know, one of the key stats, I think it's even a Cancer Research UK stat, is that 90% of patients who are referred are actually do not have cancer. The problem when you don't tell the patient is they have a very high DNA rate. And we know that within 2 weeks, it's a very expensive outpatient appointment. It's a high resource appointment. And then often when it's not DNA'd, the secondary care are forced to discharge the patient. They can't rebook the patient when it comes to a 2-week wait clinic. So it creates a lot of problems. It also means that when they turn up and everyone starts talking about suspected cancer pathways, it can be really, really alarming for the patient. So please do consider thinking about having that conversation with the patient. It is actually mandatory on the form to say that you have explained to the patient that this is a cancer referral pathway, and the DES and the QOF ask for you to performance manage the number of patient information leaflets you are giving. So it's a requirement to demonstrate that you are improving patient education and patient leaflets. So this is something which is very, very good for the patient. I understand, you know, the awkwardness about it, but please do consider kind of maybe a couple of lines that you can pre-rehearse to kind of break the ice and to introduce that to patients. Next question was, can practices have a copy of this recording to show to others? Yes, BOLA has recorded it and it will be on your CEPN BHR website for you to access, and that link will be shared around to you. Next question is, what about a fail-safe reminder if a form isn't sent? Yes, indeed. So the practice dashboard really is there for your cancer administration team to review on a daily basis. So there is definitely something to say that they'll be able to monitor to see what is happening. We are looking at essentially being able to populate some of the aspects of the dashboard to capture the ERS code to say that that referral form has sent, which is currently in the pipeline, in order to be able to then say or identify whether forms haven't been sent, because we know there is sometimes a gap there. So thank you for highlighting that, Alex. Any other questions?
I don't think there is any reason. I mean, any patients who are referred 2 weeks, they are DNAs. That's not true. It's very, very rarely happened.
In COVID as well, I think there has been a lot of challenges with DNA rates have been quite high for hospitals. It might be variable, but generally speaking, about 10 to 15% of all cancers referrals are DNA'd. So it is quite high. Not necessarily specific to your area, but nationally, it still is quite significant.
Could you just tell me, whenever I open my consultation, everything, the C side comes. Now, I missed in the beginning. How do you get it? Do you have to press that button for every patient, or in the beginning, what is it?
Yeah, so it's really there for to use when you are considering either referring the patient for cancer, or if you're unsure if they're at risk of cancer, you can select the first tab and then essentially either conduct a risk assessment or access the referral form directly. So the toolbar, it might be the case that you go through a whole clinic where, you know, you're just seeing patients with minor injuries or whatever, and you might not use the tool at all. But it might be the case that you then have one afternoon where there's lots of vague symptoms, lots of vague presentations, and you might need to use the toolbar more often. So it kind of serves both as a prompt to think cancer, but also just there in the background when you do need to use it and access a referral form quickly, or to support decision making to do a cancer assessment for a patient. So if you just click on that, the first time you click on it, you will be prompted to sign up to the tool. So we make sure that we have your correct details as well. So when you send a referral form and you send a patient information leaflet, it will come from you as the named doctor, but from See the Signs, not from anything else, but you as the named doctor being sending that messaging, as well as for referral forms. So you do need to sign up directly in order for the forms and things to be populated. But after the first time you sign up, it will sync with your EMIS and it will automatically sign you in thereafter.
Thank you.
There is another question from Alex Abbey.
Does the list of cancers diagnosed drop off after a while, as the list will be just getting longer and longer? So as these are cancer confirmed patients, the list will remain there. You can manually remove people off the list. That's absolutely fine. So it might be the case that someone's gone through skin and they have a BCC which has been removed, and actually they don't need to go through active surveillance or anything like that. So you can manually remove people off the dashboard list, and we won't automatically remove those people off just because of good practice that they're cancer patients, but you can remove them once if they're in remission, if they're not under any active surveillance or anything like that. But because treatment regimes vary so significantly to kind of, you know, I'm sure you understand what I mean, that it'll be difficult to set a time frame of how long a patient will be on that that dashboard for. What about System 1 practices? Does it all apply? Yeah. So all System 1 practices and the demo that I've just shown you, it works exactly the same. The only slight difference is that for System 1, your referral forms save in letters and communication rather than within the consultation as per the System 1 workflow. There is also a specific System 1 video demo that I can send through after this. I'll send to Bola to send it through to you all so you can see what the webinar looks like. And if you would like any practice training, we can do that as well. And a message from Lorraine is, when a practice starts to use See the Signs, should they go back over previous cancer referrals and put them on See the Signs too? Thanks, Lorraine. So it really depends on what you'd like to do as a practice. If you would like that patient to add to your practice data dashboard on that last tab, your practice data and your PCN data, we would encourage you to add those patients then on, especially for if you would like those patients to then come under the prompt for the cancer care review. So you have that kind of audit trail, and then that will contribute to your cancer confirmed audit trail and your cancer care reviews audit trail. So if you want to go back, many practices have gone back as well. You can do so.
You just mentioned about the skin cancer. Only the malignant melanomas included the cancer, not the BCCs and squamous cell carcinomas. It's only the malignant melanoma which can be mentioned as a cancer in skin cancers.
Sure. So when you send a patient through a skin pathway, it will all patients will be added to the dashboard. So at that point, when you then have the result, if it's the case that the result is maybe, like you said, a BCC, which then doesn't need to be followed up, you can then actually remove the patient from the cancer dashboard, because, you know, as you said, you don't need to be following up, or you don't need to be following up BCCs in the community. So things like that, then you can just remove those patients.
Thank you.
Anita, thank you for your message. I'll make a note of Julia's number and I'll get my team to put that in for you. I'm not sure if you've seen, I'll just post again in case, because the messages you haven't seen, but I've just put the email address. It's training@seethesigns.co.uk. Just email us if you would like instructions for laptop installations, or if you'd like training. We also can do training just for your admin team to get them used to it as well, from kind of like the safety netting aspects and things like that to manage. So happy to do admin or clinical, or admin and clinical at the same time. Again, just email us and we can set that up for you.
Just to let you know, on the 25th of June, there is a practice managers Redbridge forum. See the signs demonstration webinar will be happening on that day, on the 24th of June at 1 to 2 o'clock. Which there is Stephanie from See the Sign that will be demonstrating the same. So this is just mainly for practice managers as well. And we're probably going to be looking at backing and diagram to see if there's a need. And if there is, we will do the same thing to have it during the practice managers forum. And if there's a need in Everin as well, we will do the same. So people are aware as well. So during if there's any practice manager on board, if there's a need when we have the meeting, we can discuss that, and I can either liaise directly with B and find out who would be able to come along to the practice managers forum and demonstrate See the Sign system for those who are unable to make it to any of the webinars we've had so far.
Yeah. Well, I think it's just left to me now to say thank you very much, Bea, for a great presentation, and really thank you to everybody for your questions, and I hope that you all find this tool really useful in delivering delivering best practice for the patient and also delivering the PCN DES. So thank you very much, everybody.
Thank you.
Thank you.
Thank you.